Good morning, everyone. My name is Christina Mangurian. I'm the Vice Chair for Diversity and Health Equity, and I'm absolutely thrilled to get to introduce Dr. Carolyn Rodriguez, especially on International Women's Day. Dr. Rodriguez is faculty at Stanford University, where she's actually Associate Dean for Academic Affairs at the School of Medicine and Associate Chair for Inclusion and Diversity in the Department of Psychiatry and Behavioral Sciences. Dr. Rodriguez also serves as Deputy Editor at the American Journal of Psychiatry. As you'll learn about today, she's an extraordinary physician scientist. She's a director of the Translational Therapeutics Lab and has conducted landmark clinical trials pioneering rapid-acting treatments for illnesses, including OCD and PTSD. She's won several national awards for this work, including the Presidential Early Career Award for Scientists and Engineers, PCASE. The PCASE recognizes investigators who are pursuing bold and innovative projects at the early stage of their career and is considered one of the highest honors in scientific research. On a personal note, Carolyn and I met each other when we were residents at Columbia. Our friendship grew into one where we provide each other with support as two Latinas, women rising in the ranks of academic faculty and growing families. A lot of it was on the phone while we're commuting and or dropping off kids at different activities. She's one of my dearest friends, and my only regret is that we're not in person so I could give her a hug. Please join me in welcoming Dr. Rodriguez. Before we formally start, there will be a Q&A session around 9:20. If you have questions for Dr. Rodriguez, please submit them in the chat, in the public chat box. Or if you want to ask a question live, please do raise your hand with the reactions button. If your name is called, we'll unmute your microphone. Please make sure to change your name on Zoom if it isn't identifiable now. If you can, I know she'd enjoy folks being off video, but I defer to all of you what you'd like to do and feel most comfortable with. Thank you. All right, handing over to you, Dr. Rodriguez.
Thank you so much, Christina. Thank you for the invitation to the Grand Rounds Committee. Thank you to Dr. State. And it's so wonderful to see a couple names that I recognize. Hi, Judy. Hi, Allison. Hi, many others that I recognize. Just saying hi. Delighted to be with you today. I'm going to share my screen. Okay. Christina, are we okay?
Perfect.
Okay, great. Thank you so much. So Christina, if I were there in person, would give you definitely a hug back. Thank you for the kind introduction. Here are my disclosures in the last 3 years. And Dr. Mangurian also mentioned I'm the deputy editor for the American Journal of Psychiatry. And just wanted to share with you that my journey in academic medicine began with my PhD in neuroscience. And during my rotations through McLean Hospital and seeing patients, it just really struck me the need for that translational component. And I was really motivated by seeing patients and how there was such a gap between these burgeoning, neurobiological advances and patients really in distress. And one of the early patients that I saw during my rotations that really inspired me, his name is disguised, but was John. He was a college student, and he was struck with this surge of anxiety, and he really wasn't able to move forward. He started to have these intrusive thoughts that he needed to have his writing just right. And then he would have these behaviors where he would have to write and rewrite things until it just felt right. It felt like it was the way he wanted it. And he also had to change a shirt in the morning many times until it felt right on his body. And these behaviors impacted his ability to get to school on time, crippled his ability to be with his girlfriend. His girlfriend broke up with him, and he was really struggling. And so this is a story characteristic of somebody who has obsessive compulsive disorder. As you know, you have intrusive thoughts that increase anxiety and repetitive behaviors that serve to decrease that anxiety. And the intrusive thoughts can, drive the compulsions, which can be both compulsions that you can see, like washing hands or repeatedly checking locks or checking the news, but can also be mental compulsions. I had a patient once who, when he thought the word David, he had to think the word John to cancel out the anxiety that brought on. So that's an example of a mental ritual or compulsive behavior. As well, he would do things like he would, put Visine on his eyes and different kinds of things. So more, things that you could actually see, but a lot of them were also mental as well. And our standard OCD treatments, as you know, are medications, SSRIs, which need to be given at higher doses and for longer periods of time than depression, and cognitive behavioral therapy with exposure and response prevention. But what I noticed with John is that he had tried these first-line treatments, but still wasn't helped. And indeed, about half of individuals that try first-line treatments still have residual symptoms. And the other thing that was really frustrating to me and John at the time is the long lag time between trials. So medication trials can take 8 to 10 weeks. Cognitive behavioral therapy can take 3 months before you can see, a decrease in improvement. So I was really interested in how we can get faster acting treatments. In terms of the neurobiology at the time, neurobiology of OCD is really fascinating and has many different facets. But at the time, there was converging lines of evidence showing that there is a hyperactive circuit in the orbitofrontal cortex that drives thoughts, striatum, which drives behaviors, looping to the thalamus, and then looping back. And the theory is that, patients like John were bombarded with these thoughts and no stop signal. They just get flooded with these different kinds of thoughts. And in my research, I took a multimodal, a multi-level approach. We don't know very basic things like how are obsessions encoded in the brain. And I really wanted to try and tease apart, what level this is acting. Is receptor, circuit level, the neural network level, and how do changes at these different levels affect behavior. And one of the things I was really interested in at the molecular level was a animal model of compulsive behaviors called the SAPHAP3. And then how could we then employ novel compounds to and with animal models to be able to identify these compounds? And then how can we test those compounds in compulsive behavior? So that's a more therapeutic molecular level. And then at the circuit level, could really take advantage of superficial cortical stimulation with transcranial magnetic stimulation, or deeper stimulation with deep brain stimulation, which has FDA compassionate use approval. And so I started looking at the receptor level. And my work started out focusing on glutamate, the main excitatory neurotransmitter in the brain, as you know. And in OCD, these glutamate abnormalities were starting, and drugs that affected glutamate abnormalities were starting to have some positive pilot reports. And the animal model, SAPHAP, that I had referred to, it's a family of proteins that form scaffolding complex at excitatory glutamatergic synapses. And it has these excessive grooming behavior, anxiety-like behavior, and corticostriatal synaptic deficits. And then when you reintroduce SAPHAP3 into the striatum, those repetitive grooming behaviors cease in the animal models. Very, very interesting. And at the time, ketamine was a drug that had been tested by Berman et al. And reproduced in Carlos Zarate, showing that ketamine was a putative glutamate modulator, blocking docking ports for glutamate and had this really powerful antidepressant effect that was quite rapid. And so I was interested in then sort of merging that sort of promise together and testing it out to see if ketamine actually decreases OCD. So we conducted the first trial of ketamine versus saline, where individuals were randomized to 0.5 mg per kg, so a sub-anesthetic low dose of ketamine or saline. And we enrolled 15 patients in a small pilot study, and the order in which they got the infusion was randomized. And this is called a crossover study. And a crossover study has a nice advantage because you can actually merge the two phases of the study and give you higher power. That's assuming you don't have any carryover effect. But indeed, we did see a carryover effect from ketamine to the placebo. And so what I'm showing you here is just the phase 1 data and showing you that over time, over 1 week, we asked patients on a scale of 0 to 10, 10 being constant intrusive obsessions, how their symptoms were. And the infusion of ketamine was 40 minutes. And we see, immediately within an hour, dramatic decrease in ketamine, which is significantly different from saline. And that decrease persists. And that was really exciting for a couple reasons. One is that this dramatic effect persists long past ketamine is metabolized. Patients don't have any residual side effects after 110 minutes, and yet the effects persist. The other is that these patients were not on any other medication, so they're medication free. And so it's the first time that you're seeing a drug act through the glutamate pathway and not as an augmenter to somebody who's already in SSRI have its own effects. And finally, that it was so rapid. I'd never seen anything like that in OCD before. So the gold standard scale of responder is using the Yale-Brown obsessive-compulsive score, and half of individuals with ketamine at 1 week out had met this response criteria, were not in the saline group. And patients, really were noticeably impacted. They said they tried to have OCD thoughts, but they couldn't. One of the downsides of ketamine, as you know, is feelings of dissociation. All individuals had dissociation. 2 of them had dizziness. 1 had nausea and vomiting. And these increases in blood pressure and heart rate consistent with what we had seen in the depression studies. So again, we were really excited about the promise of ketamine. But really wanted to, dive a little bit deeper and understand, was actually this effect happening through the glutamate system, and also, there's reason for caution. The effects are transient. It's a drug of abuse, and there are real side effects, like you can't drive after 24 hours. After getting an infusion. And it's not FDA approved for OCD, and there can be variability in monitoring. So I recommend you look at 2 resources, Newport and Sanacor et al., that gives some consensus guidelines from the American Psychiatric Association Council on Research when recommending this pathway for patients. In depression, there's been, a lot of robust work in terms of meta-analyses and a lot of really exciting work on potential mechanisms. And it's highlighting that, our original thoughts about glutamate, it's not only glutamate, it can be many different downstream pathways. Very cool paper looking at prefrontal cortical spine formation and its impacts. So it's a very rich set of hypotheses and to explore. So I really wanted to understand, is it being driven by glutamate? This work, was really making me want to have some kind of tangible evidence that this was the case. And we partnered with Tacoma Shungu at Cornell and Larry Keglis at Columbia and Blair Simpson at Columbia to really look at, using magnetic resonance spectroscopy, which is an imaging modality where you can look at neurotransmitters such as glutamate and glutamine in a combined way called GLX, or GABA, which is assessing an inhibitory molecule that, in a specific region of the brain called the voxel. So you can see in images A and B here, there's a little square that we're trying to assess that. Does it change? So we had patients in the scanner getting the infusion, having MRS. And this is a fun thing about science. It really surprises you. And even though we were anticipating changes in GLX, it didn't really change. What increased 1 hour post-infusion was GABA, an inhibitory molecule. And another collaborator, Matthew Millak, did a very similar experiment. We had the same setup, same scanner, everything, but in patients with depression getting ketamine infusions. And he found that both GLX and GABA went up. So there's some hints here that there are kind of different neurochemical signatures between even different disorders. But this needs replication in a larger sample. And we've actually, gone on to do a NIH-funded 5-year study, which just ended, of ketamine randomized to midazolam, and looking at not only MRS, but also fMRI and EEG to really look at the different levels of where ketamine can be having an effect. And next, I want to transition to, the translation of ketamine back to compulsive behavior in the SAPAP3. I was very fortunate to collaborate with Lisa Ganadian here at UCSF, and to really explore, the SAPAP3 is a terrific model. What happens when we actually give ketamine back to these individuals? And what we found is that there is a frontostriatal projection that regulates compulsive behavior in SAPAP3 knockout mice. And this work was done by Dr. Ganadian and Dr. Davis, a student in her lab. And what we found was that we could give an injection of ketamine or saline, and then actually look at post-injection grooming behaviors in the same time frame as we had done in individuals with OCD. And we see here in purple, these are the knockout mice. In green, these are the wild type mice. And if it's a dark bar line, they got saline, and a dashed line is ketamine. And what you can see here is that the knockout mice have this elevated grooming bouts compared to the wild type mice. And when you look at the ketamine, it actually follows this nice trend. You can see it actually here, that it goes down very rapidly, very significantly by 1 hour, and comes back by 7 days. Whereas if you look at the wild type, that's not the case. And so we found Dr. Ganadian did a very elegant series of experiments exploring all the tools in her arsenal, including optogenetics, that ketamine increases dorsomedial prefrontal neurons projecting to the dorsomedial striatum in knockout mice, and then optogenetically mimicking this increase in frontostriatal activity reduced compulsive grooming behavior in the knockout mice. And then conversely, inhibiting the circuit in the wild type mice increased grooming. And then, as you can see here, the grooming in the knockout mice caused by optogenetically inhibiting frontostriatal activity. And so in sum, these really elegant series of experiments demonstrate that ketamine increases activity in a frontostriatal circuit that causally controls compulsive grooming behavior, suggesting the circuit may be important for ketamine's therapeutic effects in OCD, and is another piece of evidence that the circuit level is very important in terms of OCD like behaviors. And another piece of the puzzle is because ketamine has these side effects, partnering with Carlos Zarate at NIH and NCATS, they have developed a drug, a metabolite of ketamine called RRHNK, which has been studied by Todd Gould and others, and can have less side effects as ketamine. And it's gone through phase 1 and phase 2 studies, are just starting in depression. And with generous support from the International OCD Foundation, we've been able to set up a parallel phase 2 study looking at RRHNK in OCD and the dosing strategy will be informed by the depression study. So that's really exciting. We're also really looking forward to doing a deep dive on the data now that we've unblinded and really are excited to take a look. So I'm excited to share that with you, but not quite yet. We want to get more of the data analyzed and together, and just very, very excited about that. And then another direction. So since it seemed like the field was very sort of interested in glutamate, and more evidence started coming up that ketamine is a very complicated drug and acts on many different systems. Alan Schatzberg, and in collaboration with Noel Williams and Boris Heifetz, we conducted a study to really look at this, is the opioid system involved in ketamine's antidepressant effects? And Dr. Schatzberg really had this notion. He talked to me. He's like, Carolyn, isn't ketamine just like a speedball? Patients are like high and things like that. And so he's really been mulling this over for many, many, many years. But we could actually, he really designed an elegant study using naltrexone, which is an opioid receptor antagonist, to really deep dive into this question. It's very classic psychopharmacology experiment. You can actually design it so you can conduct a randomized double-blind crossover study, and then you can give patients pre-treatment with this opioid blocker in a counterbalanced manner, and then be able to see actually what is the effects in ketamine responders and how does an opioid blocker affect things. And so interestingly, what you find is, on the left-hand side, the scale is 0 to 40 from depression, 40 signaling higher levels of depression and 0 being none. And looking at this sort of 14-day post-ketamine interval, found that the naltrexone blocked the antidepressant effects, whereas ketamine, you still had that robust effect. And interestingly, it attenuated the antidepressant effects, but not the dissociative effects. So ketamine still caused dissociation. So in sum, opioid system activation is critical for ketamine's antidepressant effects. Still have to, puzzle through how we reconcile with prior research on glutamate. And, the glutamate system, one path through is that the glutamate system may drive through the transient maintenance of antidepressant response through modulation of brain plasticity in these second messenger systems, so that the opioid system may be responsible for the sort of rapid, like the high, the euphoria that patients feel, but then the NMDA or glutamate component is actually making it so that it's not immediately turned off, but that has some tail to it. So that switching gears to neuromodulation, really, really fortunate to kind of explore more. Now that we sort of identified, the converging lines of evidence, and the orbitofrontal cortex is part of, and the striatum are part of this generation of OCD thoughts, and sort of keeping in mind that ketamine has these side effects. Transcranial magnetic stimulation has the advantages of being non-surgical, and also not having this side effects of a systemic drug, so can be applied locally. And collaborating with Nolan Williams, Keith Sudheimer, Leanne Williams, and Lauren Coran, we were fortunate to get funding from a donor to look at cortical stimulation. And there is right now an FDA-approved device called the BrainsWay H7 Coil, and the target is a medial prefrontal cortex and the anterior cingulate cortex. But one of the downsides of it is that, as you see here, it's a total treatment duration of 6 weeks, and you need to come in 5 days a week. And so, it was really motivating to see if we could try and find something that took less time. Is there a way to sort of take the rapid effects of ketamine and apply that to neuromodulation? Some of the other disadvantages are when you have a deeper target, or you can get spread, and potentially you could have overlap of some of for patients with comorbid depression and OCD, an overlap in hitting these different targets. And so without very tight control, it may be that patient who is getting better from OCD, actually gets worse in their depression. So I've seen a couple of sort of anecdotal, cases of that. And so it's definitely something that, needs to be researched more and looked at more comorbidities. The other piece of it is the data for the study included personalized treatment provocation. So doing an exposure hierarchy for that individual to basically get their personalized OCD circuit online, so to speak, so that you can use TMS to target it. But because it was in both conditions, it's unclear whether this is actually necessary. And that's not a trivial thing for dissemination, because if you can disseminate the machines, right, you still need to have somebody who's there on site, who's an expert in OCD or can help with the hierarchy to be able to administer this treatment. So some of the most promising optimizations at the time that we were embarking on the study were, being able to reduce the session time, the overall treatment duration, and increasing the dose. So Dr. Williams is really proponent for, are we potentially underdosing TMS, just like with a pill, you're giving people too low a dose, you have to titrate up. Maybe there's some promise there. And then Dr. Williams and Dr. Sudheimer were really, pioneering in this personalization of target, where to stimulate. And so theta burst stimulation was one way to be able to reduce the time while keeping the similar efficacy of the 40-minute 10 hertz rTMS. It decreases the patient burden and had minimal risk to patients in studies that have been published previously. And so, as you can see here, with traditional methods, you have going from 20 minutes to 44 seconds 3 times. So around 2 minutes is a wonderful reduction. I also have here on the right-hand side, just to remind me to tell you that depending on how you're stimulating in the brain, you can often get excitation or you can get inhibition. And so we're using inhibition in our protocol to see if we can actually quiet down the circuit. So in terms of treatment duration, the BrainsWay lasts for 6 weeks, again, 5 times per day. Standard TMS treatment for other indications can last 3 to 4 weeks. And the new protocol that we're testing, have designed and tested, would be for 5 days. And then the increasing the dose, again, the standard dosing is 1,800 pulses, whereas BrainsWay was 54,000, and what we were proposing is 90,000 pulses. In terms of the personalizing target, Dr. Williams and Sudheimer created a hierarchical clustering algorithm that can be applied to each participant's resting state scan to identify personalized functional subregions. And then we do, this is the CNI here at Stanford. We do an 8-minute resting state sequence. And then we can identify the right frontal pole subunit showing the greatest connectivity across all the ventral striatum subunits. And that was selected as the stimulation target. And then you can then use, feed that point into the algorithm, and then be able to use the local light neuronavigation system to be able to position the TMS coil over the individualized right frontal target for each participant. So we did just as pilot, small open label study in individuals with OCD, and we gave them 5 consecutive days of this accelerated theta burst stimulation to the right frontal pole. And the idea is that that's the best place to actually connect with deeper structures in the striatum and apply inhibitory stimulation. And we did 10 sessions per day and used the TMS MagVenture Pro. And so what you can see here is, of the 7 individuals, the Y box goes to 40. So 40 is a very, very highest you can go. Patients were symptomatic. And then after the first week, you see here, even just for the first patient, a dramatic decrease. You've got from 28 to a 7. So that's a 75% decrease. And that's actually sustained when we keep looking out up to 4 weeks. And some individuals actually had their peak effect a little bit later on. Some had their peak effect earlier on. And then 2 individuals really didn't hit that mark at all. The side effects were very, very minimal. So I was very encouraged. There's headache, but most resolved 1 to 3 days post-stimulation for 4 individuals, and fatigue. So it was really tiring for people. And that resolved 1 to 3 days post-stimulation, and no serious adverse events. Then in collaboration with Dr. Leanne Williams, she has really done very, very elegant work in terms of subtyping depression. And one of the biomarkers that she has, a pipeline for at the CNI is for cognitive control. And when we were able to sort of weave those algorithms into the scanning that we were already doing, we found that responders showed greater decrease in dorsolateral prefrontal cortex activation during the cognitive control task using CTVS mod. And again, this is a small study, pilot data, but could be promising, and it needs replication in a larger sample. So in sum, this study is showing robust and rapid in 5 out of 7, so 71%, at least 50% reduction within 7 to 14 days. It's sustained in a subset of individuals, so 3 of the 5 continue to have these effects for up to 4 weeks. And then as a clinician, it really appealed to me that this is non-invasive, that it's minimal and has transient side effects. So a couple questions to explore further include, why do most but not all patients respond? If this is so promising, what are the differences between these patients? And second, why do some have peak response at different times and others have more durable response? So we tried to look at trends to see if there's some way to sort of distinguish this, but you really need just another study with larger sample size to really dive into these questions. So in terms of future directions, we're really excited to continue looking at next generation glutamate and opioid modulators, really try to tease out some of the side effects from the mechanisms of action, but really agnostic to the fact that maybe the side effects are actually part of what's driving things. So could dissociation or could being in an altered mental state actually be the secret sauce of these things, as opposed to the neurobiological changes. So really open to exploration there. We're so excited to, now that we have this really nice data set, explore the mechanism of action and all these different levels, and see if we can get a little bit closer to underlying mechanism and a little bit closer to where we need to target therapeutics. We're excited to launch RRHNK. This is the metabolite of ketamine, and look at the phase 2 studies, as well as continue our long-time partnership with Carl Diceroth in terms of neural dynamics, drug action. He has a NIDA P50 center, and I work on a project with Leanne Williams looking at the neural dynamics of ketamine infusions and MDMA. And really excited to continue to grow partnerships and collaborations, looking at cortical stimulation and how we can non-invasively use neuromodulation to both help reduce patient symptoms, but also understand more about the underlying mechanisms of intrusive thoughts and compulsive behaviors, and partner with neurosurgeons to look at deep brain stimulation and intracranial recordings to be able to look at specific signals and signatures of OCD. As well, we're branching out to really understand, intrusive thoughts. I've talked to you about it in the context of OCD, but intrusive thoughts have an underlying core biology, I feel, that is present across many disorders. So one of them is PTSD, where patients have these intrusive thoughts in the middle of the day that can be manifested as flashbacks. And I believe in these intrusive thoughts at night, which are causing these nightmares as well. And so, those kind of intrusive thoughts may benefit from some of the discoveries that we're making in OCD, and could they be a benefit to helping other disorders that have these intrusive thoughts? We're currently funded by the VA to look at nitrous oxide, which is a drug that is a glutamate modulator and has some opioid components as well for PTSD. So if you have any veterans who are interested in trying this out, please, reach out to us at the Palo Alto VA. I'm a consultation liaison psychiatrist there as well. The other is we're looking at, intrusive, disturbing thoughts in the setting of suicide. We also have a remote study looking at this transition of, suicide. A lot of people can have suicidal thoughts, but what is the tipping point between what leads people to have suicidal behaviors and what leads people to just continue to tolerate these thoughts? And could cognitive control be an underlying factor that could help us predict suicidal behaviors? And then finally, in depression, continuing collaborations with Dr. Alan Schatzberg, and exploring this idea of rumination. So in depression, some patients can just, again, be bombarded by these ruminative thoughts, and is, again, all of these things across the spectrum really part of an underlying foundational biology that could be targeted with therapeutics. And so, in the case of John, he was able to participate in one of our studies and, really benefited from the ketamine infusion. We also were able to give him, no cost cognitive behavioral therapy, which, really helped him and give him the tools. And he's continued with cognitive behavioral therapy and was able to actually get back to college and, continue, thriving in his life. And that's really what we want to see as psychiatrists and clinicians, really that arc of people getting better and getting treatment. So it's wonderful to see that. I really, it takes a village, really want to thank the members of my lab and a lot of collaborators and colleagues that I've mentioned here, but also, the wealth and partnership with UCSF. And just want to say that Moses Lee is, just a wonderful researcher here in his OCD clinic and doing incredible work. And we look forward to, continuing any kind of bridges or collaborations or partnerships or referrals to the clinic here. And, just really want to thank Lisa Ganaden too. I mean, really taking a chance on a clinician who was just like, hey, I really want to kind of circle back into animal models and the richness really with neuroscience here at UCSF and the bridges that you all are all creating with Dr. Stadith, pioneering that work and really expanding and collaborating across the Bay Area is really exciting. So don't hesitate to reach out if you have patients that you want to refer to us. I didn't talk about my hoarding research, but I'm happy to talk to anybody who family or loved one who is suffering with clutter. And then here are some of my links below.
Outstanding. Thank you so much, Carolyn. This was great. There's a lot of different questions already in the chat. So I'll start with Dr. Jennifer Cummings. Jennifer, do you want to unmute yourself or have Gina unmute you and ask your question? It's not working.
Can I be heard?
Yeah, you can hear. Yes.
Okay. So actually I have two quick questions. And one is I'd be really curious to go back to the slide describing people's subjective experience to the ketamine and how that played out over time with the OCD. But I'm also curious as to whether there might be any physiologic reason to believe that a ketamine infusion during TMS might potentiate the response, or is it too early to know?
Mm-hmm. So thank you, Jennifer. Terrific questions. So, that slide, I can just sort of bring a few things to life. So I had one of the patients who was coming out of the scanner. I actually, as we were coming out, we go into another room to kind of finish the assessments. And I was like, just checking my pocket to make sure that I had my key. So I always check myself. And he's like, this is amazing. Like normally that would have been a trigger for me to like think about my things, but it's not having an effect. And so there is something that is changing, in that time that people really notice. And, one of the things that I sort of mentioned was, is that state of kind of realizing how you are separate from OCD. So meaning, some people have had OCD their whole childhood. They don't know what it's like to not have OCD for those people who aren't helped. So is that brief moment of time where they can actually see what's OCD and what's me, then inspiring them? Are the healthier parts of the brain now saying like, hey, wait a second, there's something here that is interfering with our ability to do things. Another possibility is that, being free of OCD then allows you to have a giant exposure session. So he could actually then touch the doors and he could move. And so, isn't that what we're doing with cognitive behavioral therapy? We're doing exposure. So it's like a flooding exercise. So is that the way? I see Jennifer, nodding. So, I hope I answered that first question. And then the second question was about combined treatment. So I'm a big fan of this. And, it can be a challenge with NIH funding and other to do different modalities. We don't often see things kind of stacked in sequences. But if we really, as clinicians, want to get patients better, why aren't we doing studies where you try an SSRI, then you try CBT, then you try TMS, and then you try ketamine, or maybe try combinations of them. So I'm a big fan. In terms of the mechanism, ketamine, Ron Duman did work showing that ketamine in animal models increases BDNF. So that enhances extinction learning. So we have combined ketamine with cognitive behavioral therapy in a kind of an intensive session over 5 days. So there's no reason why we couldn't potentially do ketamine and then do TMS to see if those two things potentiate.
Excellent. And great question, Jennifer. I've got a question from Kevin Kingma. And so he's wondering if it's known from people who use ketamine, have ketamine use disorders, if dissociation plays a significant part in the reason for its abuse. Is I think what he's trying to say, and he's not able to be on the mic, but he was wondering if it, is if it's known that that's what it draws people to that.
I would say I don't know. And there may be substance abuse experts among you, but I think, part of what draws people to substance is, really, really deep suffering, right? And trying to find a way to not be in the situation or who they are. And so I can imagine that the dissociative component would be very appealing. But I don't have access to like a study or something to say that.
Makes sense. And then Julio Azores, can we try to maybe take him off of mute? Would you like to ask your question?
Yes, thank you, Dr. Rodriguez, for a great talk and doing this fascinating work. My question had to do with the question whether the mechanism of action of ketamine as an antidepressant involves the opioid system, and it sounds like there are clues that it does. But what about ketamine as helping with OCD? Is there any speculation or reason to think that it might also work via the opioid system, or is that just not known? Thank you.
So I recently put in a grant to the NIH that was not funded to explore this question, but there's a wonderful study, and I urge you to look at it. So Dr. Larry Curran, who is the founder of the Stanford OCD clinic, did some very elegant randomized pilot trial of low dose morphine and showed that it could be very helpful in OCD. And Tom Insel, or a former NIMH head, also has done some work in looking at opioid and opioid modulators and OCD. So it does seem to be the case that, at least in the literature that's out there, that opioid agonists seem to decrease OCD symptoms, and opioid antagonists can make OCD symptoms worse. So I have not given up on that. I think it's fascinating. And you see patients in Dr. Curran's clinic that have been many, many years on just low dose oral morphine. And the reason why that is exciting is because, even though there's an opioid epidemic, they don't seem to continue to need more and more doses because the formulation, right, is like an oral pill. It doesn't have that rush of effect. And so maybe that rush of getting really high quickly is the addictive component, whereas if you're on a stable low dose. So as a clinician, I encourage you to take a look at that work. And if you have somebody who hasn't been helped, consider that.
Excellent. Great question. And then Tony Yang. Can we unmute him?
Thank you. Thank you for unmuting me. Thank you very much for a really interesting and excellent talk. I was wondering for OCD, I'm more of an expert in depression, especially adolescent depression, but I'm wondering for OCD, have there been any studies done to test the hypothesis whether either TMS and or ketamine could be used to prime the neurocircuitry so that our standard first-line treatments, such as SSRIs and CBT, that we could increase the effectiveness of our first-line treatments?
Mm-hmm. Yeah, I love that question. I'm definitely a fan, again, of just kind of different modalities and thinking of things in different ways. Our study looking at a single dose of ketamine and then as a prime or to augment cognitive behavioral therapy, we typically were seeing 50% responder rate. And then after that, we saw like a 63% responder rate. So it did seem to have a boost, right? But the real test is like a 4-cell design study where you're randomizing to ketamine and active placebo and cognitive behavioral therapy and not. And the effect wasn't robust enough in my mind to sort of feel like that was sort of worth like a fuller exploration at that point. But it it certainly, my clinical gut sense, right, is that with OCD, it has a very big habit component. And it's hard to just with a little bit of CBT really make inroads into that. And so you really want to do like a full course where, potentially you could do like a primer and then maybe a TMS and CBT like kind of boost, but it needs to be done in a sustained manner to really change those circuits. When you talk to anybody with OCD, those thoughts are so ingrained and they've been reinforced for so many years that our therapies need to really reverse that, right? Or strengthen new circuits in just as strong as way. If you have one pathway that's so well trodden and one that's just a little bit, you need to like really boost this one in order to help facilitate.
Makes sense. And I saw Marty, it looked like you had a question too. Do you want to, Gina, could you take him off of mute? There you go, Marty.
I have a very small suggestion and then a big suggestion. The small one is that in psychotherapy research, of course, we find that ratings of the alliance, whatever the modality is, are big intermediate predictors. And I suggest, if you're not already doing it, that you have the subjects and maybe even the clinicians rate the relationship of each individual subject over time with, let's say, the person who's putting on the TMS things. And I think you'd find a slope value that would differentiate outcome. It would be a contributing variable.
Yeah. Marty, just to make sure I understand the relationship, like the bond between, is that what you mean?
Yeah. There's therapeutic alliance scales. And
yes. Actually, Marty, I'm very interested in that. So we just got funding from the Foundation for OCD Research to look at MDMA, assisted cognitive behavioral therapy for OCD. And it's going to, can imagine we're like a year out because of all the, regulatory components, but it is, with MDMA and that sort of, it's an entactogen and can help that sort of, alliance, empathy, and trust building. Could we actually, we're testing that of many mechanisms, right? Because MDMA also increases extinction learning, but could we want to test that alliance, right? Like, is it possible that MDMA is helping people do this type of therapy that's so hard to do, but putting their faith and trust in their therapist?
Exactly. Helps them feel more secure and connected. Now, the big idea, we need one of these $50 million to $100 million donors, but we could name a building after them.
Dr. State, do you want to comment on that? that's outside my pay grade, Dr. State.
That sounds great. Anyone has any ideas, please send them my way.
If we had that and could collaborate, then there's a psychedelic dissection study that could be done, because there's so many people rather informally taking, and some formally in small studies, psilocybin, ketamine, MDMA, ayahuasca, small doses of morphine, and so forth and so on. And there would be some people who would be like psychedelic tourists, and they would go and research, and one would see what works for whom and why. But it's $100 million, I think. Right.
Yeah. Well, to me, I think the challenges and the work that's been done in this space isn't enough to really inform our patients. And I strongly feel that the controls aren't active enough to really rule out functional unblinding. And so our study is comparing MDMA with D-methamphetamine. So it's the strongest control that has been documented out there. And I am fully agnostic as to whether MDMA can help OCD or not. It would be exciting if it did, but if it didn't, it would be just as informative for clinicians and our patients to say like, hey, this isn't an avenue to pursue, try something else. That could save a lot of time and energy. So I think, if I had $50 million, it would be really investing into really high quality trials to really get at, is this effect real or not, and, as well as the mechanism. But I'm going to pass it over to Moses if you don't. Moses, you're my partner in crime and OCD, and would just love to hear any thoughts of any of these questions and value your expertise as well.
Oh, you have to. He has to be unmuted, Gina.
Oh, sorry.
Actually, Carolyn, I just wanted to hear a little bit more about your hoarding research. You alluded to it at the end. I just didn't know what new studies that you had. So.
Oh yeah, definitely. So for OCD research, really kind of hit on it because we were excluding a lot of hoarding individuals from our OCD studies when I was a student, and people call me, be like, I'm about to be evicted. And I just felt like, oh my gosh. So I reached out to Randy Frost, who really kind of put this on the map, and have been kind of working with him in different venues on like more community-based research. Like, can we train peer mentors to help with hoarding? Can we do uncluttering, in-home uncluttering? Yeah. And most recently, we're doing virtual reality uncluttering. So partnering with computer, designers to be able to have like, the recycle and trash, and actually having people make decisions in these virtual environments, and then having the truck sound and actually it be taken away. Because as you can imagine, some of these homes are really difficult to work with people in. They can have dangerously high levels of clutter, but we really need to make inroads. So if we can create the experience, but virtually, it'll be better. Yeah. And then it's in pre-order, a book on hoarding disorder from the APA, American Psychiatric Association, a comprehensive guide, which is the first book on hoarding disorder for clinicians, so they can find out more about it in the latest research. So I'll pay you later, Moses.
I'm a plant, yeah.
Are there other questions that folks have? I know I was wondering, Carolyn, when you were speaking, you were talking before about, some people it works for, but some it doesn't, right? And you were saying you were really curious about that. And definitely, of course, you need a trial to explore that. But what are some of the hypotheses? What are some of the ideas that you're having around this?
Mm-hmm. Well, certainly the main one that it seems to fit is cognitive control. And what I like about this sort of psychological marker is that it can be tested remotely. So you can have a battery of tasks, and it can be administered quickly, reliably. And so any kind of tools or techniques that you can use on a sort of device and really test that out, that can be a marker or indicator, is going to be really powerful and translatable, especially with clinical trials, to be able to have markers of, is something hitting, something that could change or predict or track outcome. Any of these kinds of biomarkers are really exciting. Having a neuroimaging marker is great to study, but it isn't really going to help us get to how do we test these things in the real world and help clinicians in the clinic.
Exactly, that they could say, oh, this person tests this way, so this might be beneficial for them. Great. Other questions?
I want to say thank you. Thank you, Christina. Thank you, Matt. Thank you, Moses. Thank you, everybody who asked questions. Such richness. I have such respect and admiration for UCSF, and I'm so glad we're just right next door.
I am too. Thank you so much for being here, and let's give her a nice hand of applause and everything. And thank you so much, everyone, for being here today.